Okay, we are recording right now. We are ready to present our great friend here who is going to start a new lecture for us. This is Nuclear Medicine Worldwide, the webinar that we're doing from the Continuing Education Committee of ALASBIM to bring the nuclear world community closer to us. So I'm going to introduce um, sorry, I'm going to share something to introduce better Dr. Phillip Kuo. So, yes, we are sharing right now. Okay, that's a little bit of what he's doing. Dr. Phillip Kuo is from the United States, so he's graduated in chemistry from Harvard University, and then he earned an MD and PhD from University of Virginia. Postgraduate training included residencies in internal medicine at UCLA and nuclear medicine and radiology at Yale. He is professor of radiology, section chief of nuclear medicine, and director of diagnostics at City of Hope National Medical Center. He provides expertise in the design, conduct, analysis, and reporting of phase 1 to 3 clinical trials. He has more than 140 peer-reviewed publications and has served as PI and co-PI and numerous of NHY grants and industry-sponsored clinical trials. So that's the small part. Well, nice to meet you. Thanks to being here. So we're gonna to start if you are okay, Philip.
Yes, and thank you very much for the kind introduction. And I'm really honored to be a part of your mission here to bring nuclear medicine around the world closer together. And thank you for your efforts. So I'm going to talk today about something that I think is not as popularly known as oncology in nuclear medicine, but something that we play a very critical role in and an expanding and growing role. So I think we all really need to know about it. And the field of neurotheranostics could dramatically change in the very near future. And I hope you can understand after my talk a little bit better the potential that we have here. So the title of my talk is Amyloid and Tau PET for Neurotheranostics. This is just in case, even though this isn't a CME talk, disclosure of my commercial interests. As you can see, I do a lot of consulting and speaking for various radiopharmaceutical companies, as well as been funded in research grants from commercial interests. So quick way of learning objectives for this about 30-minute talk. We're going to describe the importance of amyloid and tau PET in the new staging system of Alzheimer's disease, understand the clinical trials underpinning the approval of these anti-amyloid antibody therapies, and discuss the relevance of the new appropriate use criteria for an amyloid and tau PET to amyloid targeted therapy. And this won't be in any particular order because I'm going to try to weave all this together for us. So let's start with Alzheimer's disease. You know, sadly, I think almost all of us have been personally touched by this devastating disease. And I apologize for the more US bent to this, but this is the projected data for Alzheimer's dementia going into the coming decades. And as you can see, there's going to be a multiple-fold increase in projected Alzheimer's disease. Much of this just due to the epidemiology of the aging population, which of course is not a pure US phenomenon. That is happening around the world. So this was the traditional method of clinical functional assessment and is still valuable. It was really based on symptoms and function. So you have this preclinical where you have the pathology in the brain, but no symptoms yet, okay? Then you have what we call mild cognitive impairment, or MCI, which can be due to many things, but here we're saying it's MCI specifically due to Alzheimer's disease. You have very mild symptoms, but they don't interfere with everyday activities. And then you start to really have the dementia that goes from mild, moderate to severe with increasing interference with your everyday activities. And of course, when it gets severe, unfortunately, you have to be assisted with almost everything. So we're going to try to stop people, obviously, from going down this cascade. So we still use this, but at least when I was in med school, which was a long time ago, I mean, this is the only thing we had, of course. But things changed. And one of the big landmark papers was in 2016, where this real esteemed group of experts, primarily neurologists, came together to finally say, all right, we're going to make a framework for Alzheimer's disease biomarkers. We're going to get beyond just that clinical description of very important, but just cognitive symptoms and really get at the pathology in a way like that we do with oncology, right? We always need the pathology, right, to understand what's going on, especially when you're trying to have therapies that are based on that pathology, okay? So this is the ATN classification system, which started in 2016, the first paper, and it stands for amyloid, tau, and neurodegeneration. And this is a paper that figure that's shown very often, but it's super important because it shows on the y-axis the degree of biomarker abnormality, amyloid, tau, neurodegeneration, and on the x-axis is time. So as you can see on the left-hand side, the first biomarker that becomes abnormal, whether you analyze it through cerebral spinal fluid or amyloid PET, is amyloid. So it plays this essential role, amyloid, of being the first biomarker to become abnormal. The next one over is tau, and then the neurodegeneration really kicks in. So one of the most important things to realize right now, even back in 2016, we were developing these biomarkers, and tau PET had already been research used and later got approved after 2016. So we have approved biomarkers in all three categories now by the FDA: amyloid, tau, and our utilization of neurodegenerative biomarker is FDG PET. Okay, you can also use that by MRI, of course, with atrophy. Now, a very important thing to point out here is this is the clinical symptoms, right? Over here, when you start to get in the green and the cognitive impairment, amyloid is the first category of biomarker to become abnormal, but it is necessary for Alzheimer's disease, but not sufficient. Okay, so you can be amyloid positive, and as you start down this cascade, by the time you develop symptoms of Alzheimer's disease, you must be amyloid positive. Okay, but you can be amyloid positive and have no symptoms. Alzheimer's disease is a disease. You have to have symptoms. You have to have cognitive symptoms. If you don't have any, you don't have the disease. So you can be amyloid positive without the disease. It is necessary for the diagnosis, but not sufficient for the diagnosis. All right, let's fast forward now to 2024. All right, we went from 2016 to 2024, 8 years. They have come up with a next stage, an evolution to that pathologic biomarker staging. It's sort of like you got to walk before you can run. So a very similar group of very excellent leaders in this field. Again, Clifford Jack was the first author again. And they've now made it even more detailed, more complex to really reflect not only where the research is going, the science is going, but like I said, at first, I think if they came out with this right away in 2016, it would have been a bit overwhelming. So now we can start running with what we have. And instead of just ATN, we have core biomarkers, biomarkers of non-specific processes, and biomarkers of non-AD co-pathology. So first, we were really focusing on Alzheimer's disease. Now we're looking at the global picture of dementia, where lots of times it's mixed. Okay, it's not just straightforward, oh, all you have is amyloid and tau, and all you have is Alzheimer's disease pathology. And within the AT, the amyloid and the tau, we have a core 1 and a core 2 biomarker categories. All right, let's start with core 1. A core 1 biomarker result is sufficient to establish a diagnosis of Alzheimer's disease and to inform clinical decision-making throughout the disease continuum. So that is amyloid PET, for our purposes, is a core 1 biomarker. This is recognized by the experts around the world as a key biomarker. Notice something important, which might change very soon. A core 1 biomarker is also tau, but they only include CSF or plasma tau, liquid biomarkers, not tau PET. Tau PET is a core 2 biomarker. And what is that? That is a later changing core 2 biomarker, okay? That can be still important provide prognostic information, and when abnormal will increase the confidence that Alzheimer's disease is contributing to symptoms. So why is the fluid biomarker of tau a core 1, but not the tau PET? That's because our current tau PET approved agents don't pick up tau PET early enough like the fluid ones do, okay? But as we get better and better tau PET agents and maybe even better scanners to accompany those better tau PET tracers, I would predict that this tau PET will migrate up into being a core 1 biomarker when we improve our ability to detect early levels of tau, early Braak staging 1, 2, 3. All right. Very importantly, they've added these biomarkers of non-specific processes to really, of course, reflect real life. Patients with Alzheimer's disease often have some vascular dementia component as well, for example. And so you're looking at biomarkers of neuronal injury. That's your anatomic MRI, your FDG PET. Also, your markers of inflammation, okay? So they have glial fibrillary acidic protein as their fluid biomarker, but certainly not approved, but in research, a common one used for measuring inflammation in the brain is TSPO PET. Has its issues, but just as an example that we have current research going in that area, maybe more in the future, we meaning not me, but the field. And then we have biomarkers of non-AD co-pathology. By the time you hit 80, there can be a lot going on in your brain other than just pure amyloid or tau. And of course, vascular brain injury comes in, or very importantly, alpha-synuclein, right? The majority of Lewy body dementia is actually amyloid PET positive. So you just can't stop at amyloid PET a lot of times. It's sensitive, but not specific. And we can play a big role there. Quite possibly the single best diagnostic test for Lewy body dementia is actually our striatal imaging, right? And in the US, it's approved with dopamine transporter SPECT, but of course, there's other PET tracers that you can use for those as well. So that is the most advanced staging now. As you can see, they're really moved completely over to biomarker staging and away from pure symptom staging. So this is their new graph, all right? It resembles the old one. Amyloid is still key in the beginning, right? And it becomes positive before you develop symptoms. But a big change has happened with tau. They've separated tau out. Before it was just one line. Now you have tau that's medial temporal lobe, which is early stage tau, from neocortical tau when it gets up into your parietal and frontal lobes, okay? Because tau is very different from amyloid when it comes to tracking with symptoms. You can have a brain full of amyloid on an amyloid PET scan that you couldn't tell the difference with someone with, moderate to severe Alzheimer's disease if it weren't for the atrophy, but you have no symptoms, okay? But tau is different, okay? When you have late stage tau, neocortical tau, you should have symptoms, and they actually might be quite severe by that point. But if you have early stages of tau, it usually tracks with MCI or mild. So tau tracks with symptoms much better than amyloid. And that's why it's given greater temporal definition here with just in the medial temporal lobe versus neocortical. And then, of course, this cascade of amyloid to tau, and then you get this neurodegeneration, which tracks with symptoms most closely. When you start to lose those neurons, that's when the symptoms are inevitable, right? Effect of existing co-pathologies, just a general sort of shifting of the graph here, okay? So if you have a vascular component in your brain, you would get more clinically symptomatic, perhaps at earlier stages of the same degree of pathology of someone who has no vascular component whatsoever. And then something that's a little bit harder to quantify, but something that's been seen in many, many studies of dementia is that when you have higher cognitive reserve, you develop symptoms later, okay, even for the same amount of neurodegeneration. So exercising that brain, as some people call it, really can help to delay cognitive loss with that cognitive reserve. Again, reflecting that it's not all about the pathology, it's mostly about the pathology, but there are other things that can contribute to final symptom. Okay, So let's look at this in the biological staging way. Again, it's starting to migrate over to what we're familiar with in oncology. So we have amyloid positive, but tau negative. That's initial stage. Early stage is amyloid positive, and just that early tau deposition in the medial temporal lobe. And then intermediate and advanced stages when you start to get that neocortical tau, moderate and then high. Let's start to look at some of our PET imaging. All right. Amyloid PET. We, in the US, have 3 FDA-approved amyloid PET tracers. They each have their own reader methodologies that were attuned to the neuropathology results that were available for these scans, but they all follow the same basic principles of image interpretation. A normal or negative scan shows uptake in just the white matter and no or little uptake in the gray matter. Okay, so it's kind of nice actually. You have like a negative control. If it's negative, it's just like it's not like you just see nothing in the brain. You're worried about you infiltrated, the entire dose in somebody's arm. You will see uptake in the white matter very clearly. And in an abnormal positive scan, you still have uptake in the white matter, but now you have uptake in the gray matter. So if I take this cursor in a white matter pattern and a negative scan, I can trace out that white matter. But when it's a positive scan, I lose that ability to trace out that white matter, right? The contrast between white and gray matter is lost. It's the same. All right. And so just to kind of show you examples of the 3 FDA-approved tracers, florbeta-ben, florbeta-pir, flotemetamol, when they're negative, they all have this white matter pattern. On the left here, I have this diffusion tensor imaging map from an MRI to show you the white matter tracks. And you can see it looks like a white matter scan from an MRI, right? Okay. And what's positive, you can't trace out that white matter anymore. Now, I want to emphasize in nuclear medicine, we're traditionally very proud, and I like it, I'm one of them, who say we're functional imagers too, right? And then we became molecular imagers. And I want to say we're going to the next step where just like pathologists in the old days, all they looked at was just the H&E slide, and they could talk about some cells and cytoplasm to nucleus ratio and all that stuff. And then they started getting specific immunohistochemistry stains. They entered the era of molecular pathology. They could say, oh, yeah, there's this specific molecule on the surface of these cells, right? Now, just like pathology has gone to molecular pathology, we have gone to become like pathologists, right? This is not functional imaging. FDG PET of the brain is functional imaging. This is like being a pathologist. This is like telling, we biopsied 100 places in your brain and we found this much amyloid load in your brain. That's what we can do now. So how does this translate? Well, right, each one of these read methodologies, amazing subjects and their families donated their brains to the research trial so that they had within a year of getting their amyloid imaging, and then neuropathologists analyzed their brains and graded how much amyloid burden was in their brains, and then they correlated that back to amyloid PET. Okay, so a positive scan means that there is moderate to frequent amyloid plaque, and a negative scan correlates to none to sparse. So in a way, we're really talking about what the neuropathology would say in the brain. All right, so we become like molecular pathologists. And this is actually the kind of dictation I do. I have an impression that says a normal or negative scan, and I take this almost word for word out of the prescribing information, indicates sparse to no neuritic plaque and is inconsistent with a neuropathological diagnosis of Alzheimer's disease. Literally put, inconsistent with a neuropathologic diagnosis of AD. Draw that direct line to the pathology, okay? On the other hand, an amyloid abnormal or positive scan indicates moderate to frequent amyloid neuritic plaques, which on neuropathologic examination has shown this amount of amyloid neuritic plaque is present in patients with AD, all right? So literally, draw that direct line to the correlation with pathology. Neurologists love that. As far as image interpretation, just for fun, if you start to read amyloid PET, this is a radiographics article some fine fellows of mine helped me to do, and we came up with some friendly signs. As you know, in imaging, we love our signs, right? So I'm just going to go over this really quickly. In the temporal occipital lobe, when you have that white matter ridge, it looks like a mountain ridge in the desert. Thank you, Google Earth. And when it's abnormal or positive, you lose that feature. So it looks like a flat, barren desert. Okay. And again, look on this MRI, see where that white matter is. It's periventricular. It's not out here at the periphery where the gray matter is. The frontal white matter, I call this the Bart Simpson sign, but if you know the networks come after me, I just call it the cartoon hand sign. But Bart Simpson's hand is perfect because he's missing a digit, right? He's got a thumb and three fingers. All right. So you have the thumb here, right? And the three fingers, right? So it's not any cartoon hand. You actually got to be missing a digit like Bart. All right. So if Bart Simpson's raising his hands up, okay, he's missing a finger, you got a negative frontal region, a white matter pattern. And when it's positive, look in the interhemispheric fissure. Okay, so it's something rare. Anatomically, your interhemispheric fissure is lined with gray matter. So if it's positive and filled in, the activity will almost touch in the midline. Okay, and we call that the kissing hemispheres. Coronals are also very useful for evaluating the frontal white matter. When it's negative, it looks like a tree in winter because you can see the tree branches. And when it's positive, you can't see the branches anymore. So it's like a tree in the summer, unless you live in the desert like I used to and got a bunch of cacti around. So we talked about amyloid PET. Now let's talk about tau PET. Again, it's been separated. And while this is, I think, a very important first step, fluortaucipir gained US approval by the US FDA in 2020. It's like a first or second generation antibiotic. Look, it's great. It's made a huge impact, but we're not just going to stop there. There's other agents that are being studied right now that will probably turn out to be better, definitively. Okay. So there is some common off-target binding you need to be aware of. Substantia nigra, choroid plexus, striatum, meninges is usually the most troublesome. Okay. And I'm not going to get into it, but it is a binary visual read. Of course, you can quantify these, but the FDA-approved method is a visual binary read, negative or positive. And just to kind of show you from the prescribing information, there are some tricky spots. For example, you can have just isolated frontal activity, and that's negative, okay? And for example, you'll have off-target basal ganglia activity, off-target substantia nigra activity as well. So got to be a little careful. And the temporal lobes are a little tricky with fluortaucipir. You have to divide the temporal lobe into quadrants. And really, due to some specificity issues and off-target issues with fluortaucipir, we only look at this posterolateral temporal. With the other tau agents that are being developed now, later generation, if you will, we can look at the very important medial temporal lobe, which was described in the staging systems. Okay, and we'll talk about that. So a positive scan consistent with the AD pattern will have increased neocortical uptake in the posterolateral temporal, occipital, parietal, precuneus region, with or without frontal activity. Like the amyloid scans, you only need one side to be positive for it to be overall positive. And a negative scan has no increased neocortical uptake, but you are allowed isolated anterior mesial temporal and isolated frontal and still be considered negative by fluortaucipir. Again, other tracers, the more next generation tracers, are read differently. You would very much pay attention to the mesial temporal region. Okay, so yeah, quick look at it now that you kind of look at the temporal lobes are critical. All right, let's look at some cases. First is a man in his 80s with borderline mild cognitive impairment versus normal. Literally, he keeps going back and forth on the testing, but now they're really finally pretty sure that he's finally gone early amnestic MCI. I want to thank my former colleagues at the Banner Alzheimer's Institute in Tucson for their collaboration and these cases that we worked on together. This is this patient's amyloid PET scan. All right. Quick and easy, right? Can we see Bart Simpson's hand? No, I can't trace it out. Just as much activity periventricular as out in the periphery. The temporal lobes, I can't make out the temporal occipital ridge. It looks like a flat plane in the desert, okay? And even the precuneus region's filling in, so it's positive in every single region. okay? Where the cerebellum is your control. Your cerebellar white matter and your cerebellar gray matter, that contrast is negative, okay? So let's look at this patient's amyloid tau PET scan, all right? This is a tau PET. Let's divide that temporal lobe into its quadrants, okay? As you can see by the fluoroscopy read, it's just barely starting to become positive here, okay? You can even look at the other side for comparison. Now, you would not do this, but the medial temporal lobe region for this fluoroscopy is probably positive because it's so asymmetric, all right? But for the fluoroscopy read, you do not read anterior to this line. But if this were one of the next generation tau tracers, you would have called this positive. Notice occipital negative, parietal precuneus negative, frontal negative. So it's isolated just to the temporal lobe. And so what would be the PET stage for this patient? Amyloid positive for sure. And we're going to be, give me a little creative license here and give it a PET stage B and say, okay, the medial temporal lobe is positive. Again, you would not do this technically for fluoroscopy, but give me a little creative license that it has been positive here. It probably is true in this case since it's quite asymmetric. All right. So that was this first case. Nice example, MCI, just the earliest amount of tau deposition, okay, and nothing higher up in the occipital, parietal, or frontal lobes. Next case, 74-year-old man who was normal in prior testing, but now with MCI, okay, his MMSE is 22 out of 30, MoCA was 19 out of 30. Some confounding things. He has some active depression, also a family history of maternal AD, which makes you more worried. Look at his amyloid PET scan. What do you think? Right? Positive frontal, positive temporal occipital, positive parietal. Notice again here in the interhemispheric fissure, it's just this thin line of lack of activity, but on both sides of that is the gray matter and it fills in, okay? So you don't have this big gap in activity as if it were negative. Tree in the summer, right? You can't see the branches, right? It's all completely covered up. All right, so every region positive on amyloid PET. What about this patient's tau? All right, we have the tau positivity in temporal lobe extending even farther posteriorly, but now we also have positivity coming up, right? It's involving the parietal regions, the frontal regions, some asymmetry, right? Not too much, if any, handling on the left side, but a moderate amount on the right side. So what stage is this patient? We're going to give him stage C. Amyloid positive again, of course, because you pretty much have to be amyloid positive before you get any tau, and moderate neocortical uptake. And our last patient, a younger gentleman, 60 years old with a master's degree, recently progressed from early to severe Alzheimer's disease. MMSE is 15 out of 30. His MoCA was only 9 out of 30. Look at his amyloid PET scan. Okay, this is the cerebellum, white matter positive, gray matter negative. That's your internal control. Temporal occipital, positive as can be. Frontal, positive as can be. And parietal as well. Every region positive again. What about his tau? Temporal, almost saturated, right? Starting to get in the occipital. Frontal is nearly saturated. Parietal and precuneus. Almost everything is entirely positive here. Is almost couldn't be greater tau deposition. What PET stage? D, right? Now we have high levels of neocortical uptake. All right, so let's put this all together. Why did I pick these three cases for you? If you were to have just stopped at the amyloid PET, they all look the same, right? If you did a centiloid or a quantification on this, they're probably 80 to 100, all of them, okay? But look how the tau differentiates, and that's why it's being emphasized in these new systems. Very early, moderate, and then late stage. And almost always it will correlate to how bad their symptoms are. But the amyloid doesn't, okay? So now before when we only had amyloid PET, people would criticize us justifiably, right? You're like, well, amyloid is necessary, but it's not sufficient, right? All three of these look the same. But now tau can distinguish, right? And it gives us a imaging biomarker that really correlates with disease severity. So will amyloid and tau PET make it into clinical practice? In the US, tau PET has not made it into clinical practice yet. Okay, fluoxetine is hard to get everywhere, where reimbursement is even more up in the air. But this will, I'm going to say, hopefully change. And one of the things that I think will help with that is when we listen to, we get together a group of experts, okay? And well, I'm not necessarily counting myself as an expert. I'm squished here in the middle. But we published an updated appropriate use criteria, or AUC, for amyloid and tau PET. And this was an amazing synergism between the Alzheimer's Association, which brought together a lot of these folks, and the Society of Nuclear Medicine and Molecular Imaging for this working group. Okay, so a great example of what happens when you bring together expertise from a variety of specialties: nuclear medicine, neurology, neuroscience, radiology, internal medicine, all came together. And we updated a much needed update to the AUC that was published for amyloid PET in 2013. And then a dozen years later, 2025, we updated it. And one of the first things that happened when we met, probably like 5 years ago now, when we started this important project, was we were charged with updating the AUC for amyloid PET. And one of the first things that came up was, are we going to differ from what we were told to do? Do we need to do AUC for amyloid and tau PET? Which is a big deal when you're a working group and you're basically charged with doing something and you're just going to go and do something else. And so we decided, if we weren't going to be almost out of date as soon as this thing came out, we needed to take on a new charge, which was the AUC for amyloid and tau PET. And so the goal of these updated appropriate use criteria was to assist clinicians in identifying clinical scenarios, all right, we're going to be clinically useful, in which amyloid or tau PET may be useful for guiding the diagnosis and management of patients who have or are at risk for cognitive decline. So this is a very dense table, okay, with a lot of clinical scenarios, okay? There's actually 17 of them, but I just want to break it down. Of course, everyone can read this at their leisure. You might have to read it a couple times to digest it all. But these are the main things. Patient populations, cognitively unimpaired. Subjective cognitive decline, which means patients complain about it, but on testing, they're normal, which doesn't mean that they're not right? Because cognitive testing is always, of course, population-based. Mild cognitive impairment or dementia syndrome and suspected Lewy body dementia. And we rated each one of these scenarios 1 through 9, where 1 through 3 was rarely appropriate, 4 through 6 was uncertain, and 7 through 9 was appropriate. And we did that separately for amyloid and tau PET. Now, I want to jump to what we're trying to drive home here. And we added these two key clinical scenarios. And we added these actually after we started writing, because when we started writing these, there was no FDA-approved amyloid targeted therapy. We actually stalled a little bit, because like, if we come out with this and we don't talk about amyloid targeted therapies and then we have approved ones, like, we got to update it right away. As you notice here, clinical scenarios 14 and 15. 14, to determine the eligibility for treatment with an approved amyloid targeting imaging therapy. Amyloid PET, the highest score, 9. And tau PET, an 8. Okay? They consider appropriate. And clinical scenario 15 is more interesting, to monitor response among patients who have received an amyloid targeting therapy. So yes, like in oncology, we're not just helping with staging, but we're also helping with monitoring response to therapy and changing directing the therapy. Amyloid PET 8, tau PET still uncertain though at 5, okay? And again, tau PET in the United States, not routinely clinically available. Amyloid PET, just big picture, is appropriate for mild cognitive impairment in general. As you can see, lots of 9s and 8s with MCI, okay? And that crosses over into determining eligibility for these approved amyloid targeting therapies, because you want to treat patients when they're as early as possible, okay, when the MCI are very early dementia. Now, amyloid PET, when it's rarely appropriate, you'll see a lot of CU here, and that means cognitively unimpaired. You should just not use this for screening, okay? Tau PET, very similar, appropriate generally for MCI. And again, rarely appropriate for cognitive unimpaired. You don't want this for just screening anybody who's cognitively normal, okay? And we have some uncertain things that we still need to work out, of course. And I want to show the uncertain list is bigger for tau PET than amyloid PET, okay? The number of papers is climbing, but tau PET has not been around as long enough as amyloid PET, so not surprising there's more. Okay, let's jump to theranostics. Theranostics, I like this terminology, there's various definitions, is a theranostic system integrates some form of diagnostic testing to determine the presence of a molecular target for which a specific drug is intended. So the era of neurotheranostics for dementia and neurodegenerative disease has already begun. This was the first drug that got approved by the FDA. And this was the phase 3 trial that got it approved. They and then now we can take a step further. We can now stratify patients with tau PET and direct patient treatment with amyloid PET. And with this graph is the principle. You become amyloid positive first, and then the cascade occurs. Then you become tau PET positive. There's this important chronology to it. And this is the key trial, phase 3 trial, that got donanemab approved by the US FDA. And this is the trial that incorporated tau PET with amyloid PET. Okay, so every patient in this trial also got tau PET. And as you can see, this, just like lecanemab, was approved on the basis of slowing cognitive decline. Unfortunately, it did not stop it, but it slowed it. And many people would use the term a modest benefit. Okay, so interestingly, amyloid can be cleared from both patients with low and medium tau. And so the combined group, where they had low, medium, or high tau, still benefited. Okay, so that's why we don't necessarily need tau PET to decide whether or not these patients should be treated. But you could, in the future, think about stratifying this way. But what was done in the donanemab trial is super important and different from the lecanemab trial. If the amyloid plaque level became negative in the trial, they used a Centilid scale quantification. You stop the therapy, right? We directed management with amyloid PET. Why would you continue to give someone an anti-amyloid antibody to remove amyloid from their brain when it's not there anymore? Okay, so very important. We're now directing management like we do in oncology with our PET scans. Okay, so amyloid is necessary but not sufficient. Here comes the big question. Once they developed symptoms in those trials, we could not stop it from declining. We just slowed it, right? But can we cure Alzheimer's disease by preventing it? If we stop this first domino from falling, if we can remove the amyloid from the brain before there's tau and there becomes inflammation and neurodegeneration, can we effectively, literally, eliminate Alzheimer's disease by preventing it? And so this is happening, all right? The same drugs that are approved, lecanemab and donanemab for MCI and early Alzheimer's disease, are in trials right now in patients who are not symptomatic. So it was actually wrong for me to say patients. They don't have symptoms. They're not patients, okay? These are patients who have Alzheimer's and amyloid in their brain, but they don't have any symptoms. They don't have the disease. And they're being treated with these anti-amyloid antibodies, which have been demonstrated to clear the amyloid from the brain. And their expected first-time readout points are in late 2027. And we might know by then, who knows, if we can actually stop Alzheimer's disease, which would almost be essentially the proof, finally, of the amyloid hypothesis, that if you can remove the amyloid from their brain and stop the Alzheimer's disease in its tracks, we have a way of curing Alzheimer's disease by preventing it. 2027, late 2027, these trials are ongoing, okay? I actually would remind people of the times when I started, as a medical student, resident, we had wards with patients with HIV and AIDS, right? Entire wards of the hospital. And it's darkest times, and we thought, are we ever going to get out of this? I mean, this devastating disease. Now you hardly see a single patient in the hospital with AIDS, right? And HIV. It can happen. Now, in neurology and clinics dementia, like, are we ever going to be able to? The revolution might be on our doorstep. I'm trying to be optimistic. And so, but the potential is there. So one of my final slides, neurotheranostics, it's key, right? We've all seen it, right? Patients living into their 80s, into their 90s, but without the quality of life, right? Because they have dementia. We shouldn't focus on lifespan. We should focus on health span. How long can we keep people not just living, but living healthy, right? With quality of life, all right? And so that's more than just Alzheimer's disease. Of course, we have to focus on Parkinson's disease and Lewy body dementia and other things, vascular dementia, not even neurodegenerative diseases. But with AD, we have a molecular target and a drug that targets that. And we plays critical role in theranostics, even though it's not a radiotherapeutic, in the diagnostic with PET. And if we have drugs for alpha-synuclein defector or SPECT, and there's trials right now for targeting tau, we have this critical role still in neurotheranostics as being the incredibly important diagnosticians to determine whether that target's there, and then to manage the patient because we assess the effectiveness of the therapy and when they can potentially stop the therapy. So I always like to end by thanking the patients and their families for participating in clinical trials. It's a huge sacrifice, time, energy, and the teams that are involved, huge teams. Without them, we would not have any of this progress. And I hope in the near future, we will be talking, I'll be invited back to talk about the huge successes potentially that the field has gone into. So I thank you so much for your time.
Well, great lecture. Thank you very much. Right now, I'm really closer to you with the brain stuff about amyloid and tau and the Bart Simpson fingers thing.
Yeah.
That's something that I'm going to remember for the rest of my life. The tree with the and the Bart Simpson fingers is really nice, really nice. Well, thank you very much for your time. Thank you very much for teaching us all of these things. We hope, as you, we hope that the um, radiopharmaceutical or maybe the pharmacy could have the opportunity to increase the quality of life for our patients. So that's something that we need to do. And that's something we're trying to do with the trials and the things that you said before. So, well, thank you very much for your time and thank you for
Thank
being
you.
here.
Thank you very much. It was an honor to speak, and I hope everyone enjoyed it. Thank you.
Well, thank you very much. Bye. See
Bye.
you.